Good afternoon, and welcome to this month's edition of our Sexual Health Monthly webinar series. We're going to wait just a moment as I see some of us joining. Today's webinar is being recorded, and this is a monthly series taking place on the third Wednesday of the month from 12 to 1 p.m. In the chat, I will share a link where you can learn more about upcoming topics. This month, we have Dr. Jason Zucker presenting on the top 25 papers. Before we get started, just a few housekeeping items. We are recording today's webinar. We do not consent to others recording this webinar or to using AI note-taking. Please put your questions in the Q&A box and not the chat. The Q&A box is located on the bottom of your Zoom screen. It may be under More. And we will answer questions at the end of today's webinar. The webinar is accredited for CME and CNE, and we will send those instructions by email later this week. At this time, I'd like to introduce our speaker. Dr. Zucker is an assistant professor of medicine at the Columbia University Irving Medical Center and the medical director of the New York City STI Prevention Training Center. Trained in adult and pediatric infectious diseases, he has extensive experience providing sexual health care to patients of all ages, as well as providing technical assistance and training around sexual health to clinicians. So, Dr. Zucker, I will hand it over to you. Thank you.
Thank you so much, and thanks all for joining us during the summertime. So today we're going to talk about STI management top papers of 2025 that will impact your management today or tomorrow. So we have a lot of ground to cover, so let's get started. A few quick ground rules before we dive in. Every paper on this list was published between January 1st and December 31st, 2025, using their earliest publication date. There are studies that landed this calendar year but were published online before that. These are my personal picks, so I'm not presenting a consensus list. I'm showing you what I found most clinically impactful or scientifically exciting. Your list can look different, and I genuinely want to hear if there's any papers you think I missed. And these papers can either support our current management or change management. So these were all original research studies, but they were duplicated by PMD across 6 queries. We looked at 42 journals, we screened 173 papers, and we started with 30 papers selected by 2 top 10 lists, 15 clinical and public health, and 15 basic and translational. And when we look at the paper library at a glance, we see that syphilis far and away dominates by disease or pathogen with about 62 papers, gonorrhea next, followed by Mpox, then followed by a bunch of other ones below that. In terms of study design, not surprisingly in the public health field, a lot were observational, but I do want to highlight the fact that we had 15 randomized controlled trials in this library, which is really fantastic for STIs. In terms of top journals represented, obviously STD was a big one, Lancet ID, JAMA Network Open, but I do want to highlight that there were 7 STI papers published in the New England Journal in 1 year, which is really fantastic. So we picked 15 top clinical and public health journal articles and 15 basic science and translational articles. And from these lists, I chose the ones that I want to talk to you about today. I'll make sure that the slides are available so you can look at these top 15 lists at your leisure. So to start with, I'd like you to meet Jill. Jill's a 31-year-old who comes for a follow-up visit. She's had bacterial vaginosis 3 times in the past 18 months. Each episode treated with metronidazole gel with an initial cure, then recurrence within 8 to 10 weeks. She's in a monogamous relationship with a male partner of 2 years. So one thing I want you to think about is, should we be treating her partner as well? And so the big question to decide whether or not it's worth treating her partner, the question really is, does treating her partner prevent the potential for BV recurrence? And this is where we have what's called the STEP-UP trial, an open-label, multi-center, randomized controlled trial of women with bacterial vaginosis in a monogamous heterosexual relationship. They randomized people to the intervention where the partners receive metronidazole twice daily for 7 days and 2% clindamycin phenyl cream for 7 days, while women receive standard BV therapy. And they compared that to a control arm where women receive standard BV therapy alone. Their primary outcome was bacterial vaginosis recurrence within 12 weeks. And they had 164 couples randomized to 82 in each arm. In terms of BV recurrence at 12 weeks, 35% with partner treatment versus 63% with no partner treatment, hazard ratio 0.37 or a 63% reduction in BV recurrence. And you can see that that's pretty clear from the Kaplan-Meier curves here that the partner treatment group seemed to do a lot better than the control group. Additionally, significantly more women were BV free at the 12-week mark, um, and partner treatment was well tolerated with no significant safety signals. So after each of these, I'm going to highlight the clinical implications as well as some things to think about. Here, it's very clear that treating partners did prevent BV recurrence. It, in fact, more than halved BV recurrence. This should not replace standard BV therapy in women, but can add significant benefit when co-administered, particularly among people in monogamous relationships with recurrent BV. It does support a sexually transmissible component of BV, and these should be shifting our guidelines. We should be offering partner treatment for women with recurrent BV. One of the things I always like to put out here at the end of this discussion, though, is who will do it. Are OBs going to be able to provide partner treatment in their clinics? That's not yet, expedited partner therapy is not yet available for BV. So this may or may not be feasible. Or are we going to be doing it in our sexual health and primary care clinics when OB refers partners to us? So just something to chew on for a second. So I also want to broaden beyond purely clinical studies and highlight a couple of transitional papers. One of them is this 2025 paper in Cell, which followed adolescent and young adult women in New York City with serial cervical vaginal sampling and routine NAT testing for chlamydia. So they did 16S RNA sequencing with and serial CT testing. And the key question was, does one of these CST types, a bacterial vaginosis associated dysbiotic microbiome, predict chlamydia acquisition, reinfection, and upper tract spread? These patients all had multiple visits over 2 years, and incident recurrent CT were assessed. So their strength of this study is that they really could look at the microbiome before, during, and after infection. It makes it a lot more informative than a cross-sectional study and can help address the longstanding question of whether some forms of dysbiosis might be correlated with chlamydia and can actually contribute to chlamydia susceptibility. What they found is that women with CST4A, a dysbiotic non-lactobacillus dominant microbiome subtype, had about 2.5 times higher odds of acquiring chlamydia in the prospective analysis, even after adjusting for behavioral factors. After treatment, women with this profile had a significantly higher rate of reinfection, really suggesting that this microbiome pattern may shape initial susceptibility and ongoing vulnerability to repeat infections. There was also a less pronounced possible signal for later or further downstream complications like PID and miscarriage, although those analyses were exploratory and based on small numbers. So in terms of implications, microbiome appears to be a chlamydia risk and recurrence driver. The vaginal microbiome is a plausible biologic risk factor for chlamydia acquisition and reinfection beyond our traditional risk factors. This particular microbiome subtype may be a biomarker that could identify women who are at highest risk for chlamydia and chlamydia complications, which in the future could allow us to target screening or treatment. And then even further in the future, microbiome-directed interventions may reduce chlamydia risk and prevent reinfection. Again, when we look at some of these basic science papers, it does not have immediate clinical implications, but this is stuff that we may see coming down in the near future. Things like being able to determine people's vulnerability to STIs by their microbiome, and maybe in the future, even microbiome-directed interventions. All right, let's switch gears now. This is Marcus. He's a 26-year-old man who has sex with men who came to clinic for persistent rectal gonorrhea. He'd had 4 consecutive over 6 months positive rectal gonorrhea tests, but not had any clinical symptoms. In clinic, his NAT was positive for rectal gonorrhea for a 5th time. However, our culture failed. And the question we had to decide was, what should we do for Marcus, who's now had 5 consecutive episodes of gonorrhea? So before we get to some results, I just want to highlight the fact that we have 2 new gonorrhea medications whose studies were published in 2025. The first one is gepotidacin. It's a first-in-class antibacterial in a class that I can't pronounce. And what's fun about Gepo is that it actually has it targets 2 different areas The DNA gear A and topoisomerase 4, different than fluoroquinolones. What's fun is because it has two targets that can reduce the likelihood of single-step resistance. Zoliflodacin, another new antibiotic, another first-in-class antibacterial, targets the gear B subunit, and it's active against gonococcal strains that have been resistant to cephalosporins and fluoroquinolones. And both of these medications came out this year, and both of them have clinical trials that were published in 2025. The first one is gepotidacin, and this was the Eagle 1 trial, a phase 3 open label non-inferiority randomized controlled trial. Looked at adults with uncomplicated urogenital gonorrhea. The intervention was Gepo 3 grams 12 hours apart. And that was compared to ceftriaxone and azithro, sort of our prior iteration of treatment that we used to use. The primary outcome was microbiological cure at days 4 to 8, with a non-inferiority margin of 10%. The bottom line is that Gepo met non-inferiority for uncomplicated urogenital gonorrhea. In the primary intention to treat analysis, microbiologic success was 92.6% with Gepo and 91.2% with ceftriaxone plus azithro. The adjusted treatment difference was minus zero point 0.1 percentage points with a 95% confidence interval of plus to minus 5. So again, it's well within the 10-point margin of non-inferiority, and non-inferiority was met. One thing I always like to highlight with these new drugs is that there was lower pharyngeal cure rate with Gepo compared to something like ceftriaxone, and we really need to be careful when using it for pharyngeal gonorrhea. In terms of safety, GI adverse events were more common with Gepo, but there were no serious safety signals. So that's one. Our second randomized controlled trial of the year was the Zorro trial, great name. Also a phase 3 double-blinded, double-dummy, non-inferiority randomized controlled trial. This one also for adults with uncomplicated gonorrhea. The intervention was Zoli 3 grams oral in a single dose compared to ceftriaxone plus azithro. And the primary outcome was microbiological cure at all infected sites at days 4 to 8 with the same minus 10% or 10% non-inferiority margin. Zoli also met non-inferiority. Urogenital cure was 91% with Zoli and 96% with ceftriaxone plus azithro, and the confidence interval remained within the non-inferiority margin. In terms of rectal cure, both arms had about an 88% cure. In terms of pharyngeal, Zoli was slightly less than the comparator, and because of the wide confidence interval, did not meet non-inferiority for pharyngeal sites. And again, we need to take care when using any of these new antibiotics for pharyngeal gonorrhea. In terms of safety, same thing with GI adverse events. So again, two brand new antibiotics that we can use for potential resistant gonorrhea, both that have concerns for lower pharyngeal cure rates. And so we really want to make sure we're screening the pharynx and really thinking about using ceftriaxone if there's pharyngeal gonorrhea. The truth is, right now, most places recommend we're conserving these antibiotics for people who are unable to receive ceftriaxone. And that's what the current guidelines are right now. It's really important that these studies came out, though, because we really, really need new drugs. And that's what we're seeing right here. Um, you know, the treatment pipeline matters a lot. This table summarizes the most recent surveillance data from the WHO, EuroGASP, and Chinese CDC, three independent programs all tracking gonorrhea resistance. And the main headlines are that we are seeing we're seeing high levels of ceftriaxone resistance in isolated places. But we know that historically, when we start to see these in certain countries, that it generally will spread around the globe. In Cambodia and Vietnam, ceftriaxone resistance is 15 to 20%. In some provinces of China, it's above 20%. Azithromycin resistance in Europe climbed from 9 to nearly 25%, and ciprofloxacin is virtually useless worldwide, depending on the region. While right now here in the US, we still have low ceftriaxone resistance rates, we have seen some of the early cases of non-susceptible MICs, and we know that we'll see more in the future. And so it's really great that we have these new options. Somebody asked about insurance coverage for the new medications available for GC. Right now, only Zoli is available commercially. Gepo is not yet available. And the biggest problem is you have to prove to them that you don't have other options. So, for example, have sensitivity showing resistance to cephalosporins before they'll approve insurance coverage for it. New York City is one of the earlier places to put out their guidance for how to use these. And what they recommended is that Zoli and Jepo should be considered in cases of non-susceptible gonorrhea, in which standard of care is contraindicated, or when a person has an intolerance of, or after appropriate counseling declines first-line treatment. These new medications should be reserved for people with few or no other treatment options, given the limited data we have on them. All right. So we talked about some of our new drugs that we're going to have. Those are available, today or very soon. But I also wanted to include one basic science paper because I think it gets at a really interesting question. One of the problems with gonorrhea is that we're treating it with antibiotics that kill not just gonorrhea, but multiple pathogens. What if we could develop a treatment for gonorrhea that kills gonorrhea selectively, including resistant strains, without disrupting the surrounding microbiome? And this study published in Nature Microbiology identified a compound called NQNO that strongly inhibited Neisseria gonorrhea in vitro, including multiple drug-resistant strains. What makes it especially interesting is its selectivity. It inhibited Neisseria gonorrhea, but actually had little effect on other commensal Neisseria species. It didn't inhibit vaginal lactobacilli, and it didn't show toxicity to human epithelial cells in vitro. So the big idea here is not just is this an antibiotic candidate, it's a gonorrhea-specific antibiotic strategy, which may help us overcome some of our concerns about treatment of gonorrhea. Sorry, I was on the wrong slide. This is the right slide. And the mechanism is really cool. MQNO triggers gonorrhea's own self-destruct machinery, which disrupts it just for Neisseria gonorrhea, leaving commensal bacteria intact. In vitro, it also worked on multi-drug resistant strains, including those resistant to ceftriaxone and azithro. And in vivo, demonstrated efficacy in a murine gonococcal infection model. The discovery of this drug really opens up a new class of gonorrhea-specific antibiotics that exploit the organism's unique toxin antitoxin system and potentially spares the microbiome. The fact that it works against MDR strains is critical because we know, as we saw earlier, that more resistant bacteria is coming. And the selectivity for Neisseria gonorrhea is really a major advantage over broad spectrum antibiotics. This is very early stage, but the proof of concept is really exciting. So in this case, because Marcus had had gonorrhea 5 times in a row, someone elected to treat him with our alternative regimen of Gent-and-Azithro. At follow-up, he tested negative, but also expressed interest in doxypep. He said that he doesn't like taking pills, but he wants to know if doxypep will work for him for like the next couple of years. So the first question I want to talk about is what do we know about the durability of doxypep? And this paper asks a really practical question. Does doxypep still work once it moves out of clinical trial settings and into routine clinical use? And is it still effective at 96 weeks or about 2 years in real world use? So this was a real world study from a large sexual health clinic in San Francisco. They used a controlled interrupted time series design rather than a randomized trial. The investigator followed patients on PrEP over 96 weeks, comparing STI trends before and after doxypep initiation, while also using a control group of patients who never started doxypep to account for community trends. In total, they had over 4,500 patients, about 2,500 taking doxypep during the study period. And the main takeaway is that doxypep remained strongly effective for chlamydia and syphilis through 96 weeks, with a much more modest effect for gonorrhea. You can see here chlamydia had an 83% reduction in incidence at 96 weeks, syphilis 79%, so pretty close to that 81% combined outcome we saw in the clinical trials, while gonorrhea had smaller and less consistent reductions, which really raised concern for doxycycline resistance in gonorrhea. So from a clinical standpoint, what can we take from this? Well, doxypep maintains strong, durable protection against chlamydia and syphilis through 2 years, which is reassuring for long-term use. Gonorrhea benefits limited. Doxypep should not be relied upon to prevent gonorrhea. And it really supports expanding doxypep access while monitoring for antimicrobial resistance at the population level. In terms of 2025, there were a lot of papers published in 2025 looking at doxypep effectiveness. And on the whole, what you can see here is that for chlamydia and syphilis, even in the real world, reductions were pretty substantial. While reductions for gonorrhea were either much more modest or there were no reductions in gonorrhea And in one case, it actually increased significantly. One other thing I wanted to highlight is I did put two 2026 papers on here, which I said I was not going to do. But this second one by Tim Menza, I really wanted to highlight. They looked at syphilis cases in Kings County from 2017 to 2025, and they found a 52% overall reduction in syphilis among cisgender men. That's not surprising because we know they have used a lot of doxypep out there. But what was surprising is that they actually saw a 53% reduction in cisgender women as well. And so there may be some population spillover that we're beginning to see with doxypep and reductions in overall rates of STIs, which would be really important to know. Yeah. All right, moving on. Next is Sophia. I'm just going to take a drink real quick. Sophia is 14 years old and comes in for her annual well visit. Her mother missed her HPV vaccination at age 11 due to COVID-related disruptions. They're ready to start now, but her mom identifies as vaccine hesitant and asks, does she really need all three doses? So can she be protected with fewer doses? So this was a double-blind, one by one by one by one randomized non-inferiority trial in Costa Rica. The population includes 20,330 girls aged 12 to 16 from 2017 to 2020. The four arms were one dose of bivalent vaccine, two doses of bivalent vaccine, one dose of non-valent vaccine, two doses of the non-valent vaccine. And the primary outcome was incident or persistent HPV 16 or 18 from month 12 to 60, with a non-inferiority margin of 1.25 infections per 100 participants. The bottom line is that one dose was non-inferior to two doses for both vaccines in preventing persistent HPV 16 or 18 infection over 5 years. The vaccine efficacy was greater than 97% in all four trial groups. And there was no meaningful safety difference between one dose and two dose regimens, and no new safety signals identified. So, this study called Escudo confirmed that a single dose of either bivalent or non-valent vaccine is non-inferior to two doses for preventing persistent HPV 16, 18 through 5 years. Vaccine efficacy was extremely high with a single dose. Single dose schedules can dramatically expand coverage in resource limited settings where return visits are a barrier. And the WHO already recommends single dose schedules. What I want you to take away from this is not that we should be switching to single dose schedules, because again, we don't necessarily know about the durability beyond 5 years. But what I want you to take is the value of single dose therapy. So that if a patient comes in and they're vaccine hesitant and they're not sure they're going to go through with all three doses, what this tells us is that it's worth it to give them one dose now. Just because they're not willing to do all three doses doesn't mean it's not worth giving them one dose. If they may not get all three doses with you, they're coming in one day and they may switch providers. It's still worth giving them one dose when you have them in front of them because you do get all this considerable protection for them. And so if you have a patient in front of you who needs HPV vaccination, give them their first dose now. Still encourage them to get further doses, but you can start right now and it provides a lot of benefit to the patient, even if it's all they ever get. Hmm. Sorry, guys. I'm having a little technical difficulty here. All right, here we go. Meet Andre. So Andre is 32 years old. Um, he presents with 5 days of painful genital and perianal lesions. Confirmed Mpox on PCR. Fever resolved 2 days ago, but diffuse active lesions are seen on exam. He's not vaccinated for Mpox. Um, sorry. So he confirmed Mpox and PCR. His fever resolved, but he still had active lesions seen on exam. He was never vaccinated because he didn't think the shot would help. And he said, I know people who are vaccinated and still got Mpox. So Andre's question is, would the MVA-BN or the Mpox vaccine have made a difference? So this is a case control study of cisgender men with Mpox who are with Mpox in California. They had a vaccinated versus unvaccinated comparison. The outcomes were disease severity, which included disseminated lesions across multiple anatomic regions, hospitalization and time to lesion healing, and the analysis included inverse probability weighting to adjust for confounders. And they had 268 Mpox cases. In terms of disease severity, Jynneos reduced progression to disseminated Mpox lesions by almost 60%. In terms of hospitalization, it reduced hospitalization by 85%. And there were significantly fewer lesions in vaccinated individuals when compared to unvaccinated individuals. What you can say very clearly is that Jynneos vaccination reduced mpox severity and hospitalization, even in breakthrough infections. The findings do support vaccination in vulnerable populations like men who have sex with men and sexual health clinic attendees, regardless of the current outbreak status. Many people are saying, oh, I don't need mpox vaccine now. There aren't cases. There are still cases. They do pick up every fall. Um, and so we want to make sure we're vaccinating people now before the late summer, early fall when cases increase. Breakthrough infections can still occur, but vaccinated individuals will have milder, shorter, and less severe illness. And we really want to reinforce the importance of mpox vaccination. So we answered the question, it would have certainly made a difference in his disease course. He also wants to know, what does having mpox mean for him long term? And for that, we have this great study out of Belgium, which was a mixed prospective retrospective cohort study of 237 adults with mpox virus infection. 210 had been previously vaccinated with a median age of 40. They were compared to 210 vaccinated adults with a median age of 40, 96% were male. They had scheduled visits at 8, 16, and 24 months after infection or vaccination. And they looked at physical and mental health sequelae, mpox persistence in different compartments, and antibody dynamics. The main clinical finding was that scarring is the dominant long-term sequelae of mpox. At follow-up visits, scarring was present in 46% of participants at 8 months, 30% at 16 months, and 32% at 24 months. So even 2 years later, about 1 in 3 patients still had residual scarring. These body maps that you can see here show these scars were concentrated on the face, hands, and genitals, which it explains why they matter clinically, even when patients report relatively limited effects on function. Most of the other symptoms improved much more than the scarring did. Fatigue, reduced fitness, pain, and self-reported mental health problems generally declined over time and largely resolved within a year. By contrast, the persistent problem was scarring, not systemic disease. On the virology side, there was no prolonged viral shedding in any compartment, and so no evidence of a long-term infection problem. And immunologically, the one big takeaway is that natural infection produced a stronger and more durable antibody response than vaccination alone, meaning that people who had prior infection likely don't need doses of the vaccination as well. And so just to summarize that, scarring is the dominant long-term sequelae of mpox, about a third of patients at 2 years. We want to counsel patients about this up front, particularly those with extensive facial or genital lesions, and try to link them to either wound care, dermatology, who can help reduce that scarring as much as possible. Vaccination induces a weaker antibody response than original infection, suggesting that patients don't need vaccination post-infection. And long-term mental health impacts are real, but largely resolved by 12 months. We want to make sure that we're proactively screening for psychological sequelae at follow-up visits, especially in patients with severe or disfiguring disease. So we talked about vaccination. We talked about long-term. We're wrapping up the visit when he mentions, oh, by the way, my sister lives with me and she's pregnant. Is that an issue? One of the things I always like to highlight is that when the 2022 outbreak started, we had very limited data on mpox infection in pregnancy. In fact, there are only 4 published cases in the literature. We now have a pooled prospective cohort from 4 different studies that included 89 pregnant women or adolescent girls with PCR confirmed mpox clade 1, with all 3 trimesters represented. These were from across the DRC from December 2022 to June 2025. And the outcomes they looked at were fetal loss, congenital mpox lesions, neonatal death, maternal death, and preterm birth. The key analysis was univariate analysis of risk factors for adverse outcomes, including trimester, viral load, HIV status, and route of exposure. And I think from this chart, orange is pregnancy loss, while dark blue are healthy neonates, and light blue is congenital infection. You can see pretty quickly what the outcomes are. 51% of women with known outcomes had adverse pregnancy outcomes, 45% fetal loss, 16 spontaneous abortion, 4 missed abortions, 11 stillbirths, and 4 neonates born with congenital mpox lesions. If you're looking for positive news, there was no maternal deaths reported. All mothers recovered from mpox. And you can see here that the first trimester risk has the highest when compared to the second and third trimesters in terms of negative outcomes. Other risk factors, including high mpox viral load, sexual contact with an index case, and HIV positive status, all resulted in more negative outcomes. So, in terms of clinical implications, we've learned that mpox clade 1 carries extremely high fetal risk among pregnancies with known outcomes. About half had adverse outcomes, mostly fetal loss. First trimester infection is the most dangerous. We want to counsel pregnant patients on this risk, particularly in endemic settings or during outbreak exposures. People living with HIV who are pregnant need heightened urgency around mpox prevention and early treatment. HIV infection was associated with higher risk, although based on small numbers. And these data really underscore the urgency of including pregnant patients in mpox preparedness, prevention, and treatment strategies. Sorry, I'm having a little technical difficulty. There we go. Okay. All right. Next up, meet Priya. So Priya is a 29-year-old who's 16 weeks pregnant, diagnosed with early latent syphilis by her OB. She had a negative RPR 9 months ago. Her OB submits an e-consult asking if she needs one dose or three doses of BPG. So the question is, does she need one dose or three doses of benzoyl penicillin G? All right, so this was a randomized controlled trial that asked that question. Multi-center, open-label, non-inferiority randomized controlled trial of adults with primary, secondary, or early latent syphilis. The intervention was BPG times one dose. The comparator was BPG times three doses weekly for 3 weeks. So one dose a week for 3 weeks. And the primary outcome was serologic response at 6 months. They randomized 249 participants and were at 199 that had valuable outcomes. In terms of serologic success, 76% in single dose versus 70% in three doses in the intent to treat analysis. It met this pre-specified non-inferiority margin, and response rates were similar in participants with and without HIV. So essentially, the clinical implications are that single dose BPG is non-inferior to three doses for early syphilis. And the current CDC guidelines already recommend single dose for primary and secondary syphilis, three doses only for late latent. So these data really don't change that, but they strengthen the evidence base for existing recommendations. With that said, there's a lot that we can still learn from this trial, actually. So, she got her BPG and after getting home, developed fevers and chills. She called her OB in a panic, wondering if it was dangerous. And so when we look at this, what she actually had was the Jerick-Hersheimer reaction. And this was a pre-specified analysis of this study. They found that, this was a pre-specified analysis. And to do that, they had a structured assessment with follow-up with 24 to 72 hours after injection and symptoms assessed through 7 days. They were trying to look at the frequency of Jerick-Hersheimer reaction, duration, and what it was associated with. And so this information is really helpful for counseling our patients that we're giving BPG to. We now have a much better idea of how frequently this occurs. About 24% of patients experience a Jerick-Hersheimer reaction after the first dose. The median onset was 4.9 hours, median duration 12 hours after injection. The most common symptoms were myalgias, chills, weakness, fevers. Risk factors, people with secondary syphilis had almost a 3 times higher risk of developing JHR. And while people who are HIV positive actually had a lower risk for JHR. And interestingly, JHR was associated with higher serologic success, about 85% versus 69%. So when we start counseling our patients, we now have a lot more information to give them. We know that JHR occurs in nearly 1 in 4 early syphilis patients treated with BPG. We can counsel patients to expect flu-like symptoms within the first 24 hours. We now are confident that this is not an allergy or treatment failure. It actually reflects an immune response to spirochete killing and resolves with a median of 12.8 or about 13 hours. It's more common in secondary syphilis, about 3 times more common, and in HIV negative patients, likely reflecting a higher treponema antigen burden and intact immune activation. And it's associated with a higher likelihood of serologic response. So it's actually a good thing in some ways. All right. Next up is a really interesting paper. So this I included because it asks a very contemporary question. Can generative AI actually help create new antibiotics for pathogens where our pipeline is running thin, like drug-resistant gonorrhea. So this is not a clinical trial. It's not a ready-to-use drug. This is a proof of concept discovery study suggesting that AI can propose entirely new chemical structures that can actually be used to develop drugs. So the focus here is Neisseria gonorrhea, including ceftriaxone and azithromycin-resistant strains. They have a generative model trained on known antibiotics to generate novel scaffolds that could be active against gonorrhea. Their top candidates were actually synthesized and tested um, in a mouse model of efficacy. So initially, AI generated millions of candidate molecules. 24 were synthesized and 7 showed selective antibacterial activity. In terms of in vitro activity, the lead components were an MIC less than 2. Sorry, the lead compounds had MICs less than 2 against MDR gonorrhea strains, and they were low cytotoxicity to human cells, so they were selective bacterial killing, meaning they're likely to be safe for humans. In vivo, the lead compound significantly reduced gonococcal burden in a mouse vaginal infection model. And so this is really neat because it suggests that generative AI can help identify novel antibiotic scaffolds with in vitro activity and early in vivo proof of concept. Potentially, antibiotics have always been hard to develop because it's expensive to develop a drug, and antibiotics are not, they can't charge as much for them. But this could potentially shorten the antibiotic development timeline for priority pathogens, making it more cost effective. It can help us bypass existing resistance mechanisms, which is important with MDR gonorrhea coming along, and provides really compelling proof of concept for AI-assisted antibiotic discovery that may lead to further investment in this approach for both STI pathogens and other pathogens as well. Yeah. In terms of summary for today, just want to review what we talked about. We talked about bacterial vaginosis, where we should consider treating male partners with topical Clendin or metronidazole to prevent BV recurrence. Partner treatment cut recurrence nearly in half at 12 weeks. In gonorrhea, we have 2 new oral options, Gepo and Zoli, that are both non-inferior to ceftriaxone. We do want to reserve them for ceftriaxone resistant or allergic patients. And right now, they're not for pharyngeal gonorrhea. We really need more information. Doxypep at 96 weeks. We want to continue offering Doxypep to eligible men who have sex with men and transgender women, especially for chlamydia and syphilis prevention. But we shouldn't be relying on it for gonorrhea prevention. The gonorrhea effect is small and inconsistent due to tetracycline resistance that's growing. In terms of single dose HPV vaccination, 1 dose was non-inferior to 2 for preventing HPV 16 and 18. It can simplify vaccination logistics, especially in low resource settings. The US schedule still recommends 2 doses before age 15 or 3 doses in older immunocompromised patients, and that's the goal. But we recognize now that giving a single dose, even if we're worried patients may not come back, is worthwhile because we provide them at least 5 years of excellent protection. From Mpox, we have 3 key findings. The MVA-BN vaccine reduces severity and hospitalization. Scarring persists at 24 months. And clade 1 in pregnancy with high fetal loss and risk of congenital neonatal infection. In terms of early syphilis, single dose BPG non-inferior to 3 doses for early syphilis. And the Jarek-Hersheimer reaction occurs in about 24% of early syphilis patients. We should be counseling everybody. In terms of basic science, the microbiome is a risk factor. BV-associated vaginal microbiome is an important biologic risk factor linked to acquisition and reinfection of chlamydia. We're working on developing selected antibiotics against MDR gonorrhea that activates gonorrhea's own toxin system. And AI-driven antibiotic discoveries here. Generative AI can design de novo compounds with selective activity and in vivo efficacy against MDR gonorrhea. It's really compelling proof of concept of what AI can do for antibiotic discovery. It's really an amazing time to be working in STIs. Again, we're from the STI Prevention Training Center. If you have any questions, please let us know, and I'll stop and take any questions now.
Thanks, Dr. Zucker. We did have a few questions come in that I think you answered during your presentation. But just as a reminder, if anyone has any questions, to put them in the Q&A box. There is another question that came in about, given the persistent shortages of Bicyl in LA, how are clinics prioritizing their supply if we are forced to use alternative regimens like Doxy for non-pregnant adults? Is there a treatment success rate? What does that look like?
Yeah. So that's a whole other talk we have.
Mhm.
So
I
the
know.
recommendation right now is we have a severe shortage of BPG in this country. Unless you're able to get lenticillin, which is, I think, the Portuguese BPG, which is FDA approved. Well, FDA is allowing its importation right now. You can use that. If you don't have access to that, then doxycycline really for everybody but pregnant women and neonates who can only get BPG. The doxy is thought to be very effective. We don't have great data on it, although we have a couple of observational studies from the past couple of years that suggest the efficacy is quite high. The biggest problem with doxycycline is for something like late latent syphilis, we're asking people to take two pills twice a day for 28 days, which is really hard to do. And even for early syphilis, it's still two pills a day for 14 days. So it's really an adherence problem more than it is a does the drug work problem. But right now, I would conserve as much BPG as you can for pregnant people and neonates who can only get BPG. The most recent update we got is that they're not expecting the BPG supply to resume until late 2027 now. So fourth quarter 2027. So we have a whole nother year plus of this to go on.
Okay, thank you. And a question about doxypep. For patients who don't strictly meet the CDC criteria, cisgender or individuals without recent bacterial STI diagnosis, but request it, how do you navigate that risk benefit discussion?
Um, yeah. So, this is a lot different than other things because we generally have not made antibiotics widely available to people. We discourage them from taking antibiotics for colds and other things. And so it's really a careful discussion about sort of what their anticipated benefits are versus their risks. You know, if you look nationwide, an extremely low number of cisgender females have received doxypep, and given the data we have, that's probably appropriate. Many of us have provided it to a small number of people who are particularly vulnerable, maybe people who engage in sex work and other things, with after a careful and long discussion about we don't know if this will work, but it could work, and here is the option. So in general, I don't prescribe it unless people's vulnerability is particularly high. The same way we would treat antibiotics for anything else, where we discourage use unless we think there's a benefit.
Okay, thank you. We don't have any additional questions right now. And so I think, unless Dr. Zucker, you wanted to add anything, I think we can add a little bit of time back to everyone's day today. Okay.
Great.
Well, thank you all for joining us. We did put a link in the chat for this webinar session. We will send out information on slides as well as CE instructions. We want to thank all of you, especially Dr. Zucker, for joining us today, and we hope to see you on a future webinar. Thank
Awesome.
you.
Thanks, everybody.